Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Pap Smear Management Update. Our objectives today are to discuss the rationale of the current Pap smear management approaches based on the latest ASCCP Guidelines, to discuss appropriate counseling and referral of women with abnormal Pap smears, discuss the latest Alabama Department of Public Health Pap smear protocol guidelines, to describe the effective interviewing techniques for educating our patients about results and receiving the HPV vaccination. So if you have any questions about anything being discussed today, please call or email us. Excuse me, the phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and for today's program. The Alabama Department of Public Health is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited approver of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be awarded for 2 years from today's date, which is October 29th of 2013. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. ADPH does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. The Alabama Department of Public Health is now charging viewers who are not employees, contract employees, or retirees of the ADPH for CE certificates. Registration and participation in both our live and on-demand programs will continue to be available at no cost. More detailed information and specific instructions can be found on our website. Also, please note the content of this program is based on the policies and procedures of the Alabama Department of Public Health, Alabama and federal statutes, rules, regulations, and guidelines. Viewers not employed by the ADPH should always check to clarify whether the content is accurate according to the statutes, regulations, and policies of your respective jurisdiction or agency. My name is Laurie Stout. I'm a nurse manager for the Bureau of Family Health Services. Also, I have Dr. Grace Thomas with me this morning. She is the Assistant State Health Officer and Director of the Bureau of Family Health Services. Thank you for being here, Dr. Thomas.
Thank you.
We have a lot to cover today. So let's go ahead and get started. So, I think we can all agree that we've had a lot of change in the Pap smear world in the last few months. There's a lot going on and a lot of advancements. So I think we would all agree that really Pap smear screening in and of itself is a success story for us. For this country, with the advent of HPV testing, it has taken screening and treatment to a whole new level. Of course, with advancements comes change, sometimes a lot of change. However, we're very pleased with the changes that we've received this year. I think a lot of the guidelines have become more specific than we've had in the past. They're using terms such as preferred, and acceptable, and generally speaking, when they're using that term preferred, those recommendations have a more robust evidence behind them than we've seen in the past. Now, having said all that, it does involve change, and we certainly want the nurses to know how much we appreciate their understanding and how much we do try to make the protocol clear and keeping abreast of all the latest changes. But I think just the fact that a lot of this new study is evidence-based, it really helps to solidify our protocol. So would you agree that evidence-based studies really help us develop our protocols, Dr. Thomas?
I do, Lori, and I echo your sentiments. I strongly, or I should say I appreciate greatly the efforts of all the nurses, nurse practitioners, and everyone in the county to adapt to these changes that seem to be frequent. But the discovery of HPV as the causative agent of cervical cancer and pre-cancer changes has truly revolutionized the way we understand the causes of cervical cancer. We know that we're on a continuum when we look at cervical disease, and HPV infection is where things kind of all get started, and we know that it's essential to have HPV infection, to have cervical cancer, or to develop cervical cancer, I should say, and precancerous lesions such as SIN2 and SIN3. So for the most part, HPV infection is benign. That we know. Those are things that we know, and we know that the precursor for cervical cancer is SIN3, and that has to be in place. That's the immediate precursor to cervical cancer. So armed with all this knowledge, we can really provide the best evidence-based care for our patients, and that's our ultimate goal. You know, when we look at the new guidelines, things are pretty much the same and continue on the same, seem to be trending in the same direction. There are a few changes, but screening, treatment, and follow-up are basically on the same continuum. We've seen an extension of the screening interval, or I guess a lengthening, I could say, of the screening interval. Co-testing is being encouraged, and the treatment of young women, adolescents in particular, is being discouraged.
Right, and there's so much that we will be reviewing the guidelines as well as the protocol changes as we go along. So where did these guidelines come about, and what are we following? Well, the changes in the guidelines came about in March of 2013. The American Society for Colposcopy and Cervical Pathology, also known as ASCCP, released their updated consensus guidelines for managing abnormal cervical cancer screening tests and cancer precursors. Now, this was basically a final compilation of a lot of their study and getting together on and providing these guidelines to providers out in the community. So for these guidelines, the group that pulled this together consisted of 47 experts, and they represented actually 23 professional societies, national and international health organizations, and federal agencies. And in addition to data review for specific issues, data from approximately 1.4 million women provided evidence on risk of precancer and invasive cancer, and this was over an 8-year period of abnormal tests and follow-up. And so all of this information has led us to the changes that we'll be discussing today. And Dr. Thomas mentioned it, but let's kind of review sort of as a snapshot some of the major changes that they included in these guidelines. The first was, or included, that cytology that's reported as unsatisfactory requires repeat, even if HPV negative. Of course, you know, we've been doing this, but you know, just sort of as a brief overview, it is important to repeat an unsat result. Wouldn't you say, Dr. Thomas?
It's absolutely important to repeat an unsat cytology, because you want to make sure that there is nothing that will obscure the reading of the Pap smear. We tend to get less unsatisfactory PAPs these days because we are using liquid-based cytology as opposed to the conventional Pap smears. So it sort of eliminates all that blood or inflammation that we might see or we would have seen on a previous conventional slides or pap smears. The issue for us a lot of times is the scant cellularity. There are not enough squamous cells there for the cytopathologist or cytologist to read adequately. So it can be a technical problem, it could be obscuring inflammation, it could be scant cellularity that leads to an unsatisfactory pap. But the bottom line is that it needs to be repeated because it may be a harbinger of underlying disease.
Great, okay. Now, another change that we'll be looking at today, and probably talking about more than most results, are the HPV negative and ASCUS findings. However, what they tell us is that these results are actually insufficient to allow exit from screening at the age of 65 years. So for many of us, an ASCUS negative pap in the past was negative. What we've found in these studies is that it's really there still remains some risk there. And so we clearly wouldn't want to exit a patient at 65 with these findings, would we, Dr. Thomas?
And I think this is one of the biggest changes that has come across with these new guidelines. This guidance from ASCCP came out of a very large study out of Northern California, the Kaiser Permanente group, which is a large integrated healthcare system. And what Kaiser did in a nutshell was to look at women, the SIN3, the cervical intraepithelial neoplasia 3 risk for women aged 30 to 64. Remember that SIN3 is necessary in order, it's a precursor, it's the immediate precursor to cervical cancer. So they looked at the risk for women aged 30 to 64, and what they found is that the risk for SIN3 in this group of women was substantially higher than women who had a negative PAP and a negative HPV, women that we would screen every 5 years. What they found was that women who were ASCUS negative were more akin or were more alike to women who had negative PAPs only, no HPV. So they were more similar, this group of women, ASCUS negative women, between the ages of 30 to 64, were more similar in terms of SIN3 risk to women who had just a negative PAP. And so we know that the guidelines recommend that women who've just had a PAP only, that we screen every 3 years. So the recommendation from this Kaiser study is based on a principle called equal management for equal risk. So women who are ASCUS negative are screened or looked at every 3 years as opposed to every 5 years because there is a greater risk of SIN3 associated with ASCUS negative smears. The other thing that this study, this large Kaiser study revealed is that the risk of cancer in this group, of cervical cancer in this group, seemed to be in women, in postmenopausal women, age 60 to 64. Hence this new guidance, and I know this is a little confusing because we've kind of like gone around quite a bit in terms of what the types of guidance we've gotten from these national organizations. But what the study also points out is that women, postmenopausal women aged 60 to 64 who would have been exited from screening with an ASCUS negative PAP because of this new finding and this new study, these women need to be followed a lot more closely because they are at risk for SIN3 or cervical cancer.
Okay. And we'll be talking more along these lines as we go along. You'll hear more about that study in just a bit. So another example of some of the change that we will be reviewing is that cytology reported as negative but lacking the endocervical component can be managed without early repeat. Now, you know, we've dealt with those types of results all these years when the endocervical component is not there. But I think what we're learning now more is that it doesn't necessarily confer with risk. We certainly need to repeat, but maybe not as we once did in 3 months. Do you have any thought about just the endocervical component there?
Yeah, I mean, I'm from the old school, and my feeling is that this will come full circle, but for now, all the studies seem to show that there is not an increased risk for women who are lacking an endocervical component. In other words, there's no increased risk for SYN3. Remember, again, I'm going to keep saying this over and over again, it's the precursor, it's what we need to have in place. SYN3 is what we need to have in place in order for cervical cancer to develop. So there seems to be no increased risk for SYN3 in women who are lacking an endocervical component on their pap smear. Hence the guidance to repeat, you know, annually or routinely or however you want to term it.
Right. Okay. Now, another finding through this study was that more strategies incorporate co-testing to reduce follow-up visits. I find this interesting. I think one example that we're seeing more and more is that co-testing is now offered more in the post-colposcopy setting than we saw before, so that's a good example of that. PAP-only strategies are now limited to women younger than 30 years, but co-testing is expanded even to women younger than 30 in some circumstances. I think a good example of that, we've already talked about the ASCUS negative patient, but in that patient who's 25 to 29, they get an ASCUS, they get it reflex to an HPV. We're finding that the recommendation is to co-test those women in 3 years. They may still be in their 20s. So that's a good example of when we would co-test under 30 in that setting. And then I think our biggest change that we have found since we started all this back in July is that they have clearly carved out a different path, so to speak, for the women aged 21 to 24 years, and they are managed more conservatively. I think, you know, that a lot of that has to do with the HPV factor in the mix and the prevalence there. Can you speak to that briefly, Dr. Thomas?
Yeah, I think that we know that HPV is, I don't want to use the term ubiquitous, but I will. It's pretty much commonplace with sexual debut. So whether or not you or I acquire or someone acquires HPV infection is dependent on how robust our immune system is and how our system responds to the virus. I think that what we do know is that in women who are post-adolescent, that is when the HPV prevalence is at its highest. And so you see infection come and go, and studies have shown that infection will clear within a 2-year period. So we have really reverted to not treating women and doing more observation so as to prevent less harm to patients, as well as anxiety, because you know there is a stigma associated with HPV infection, and so it can produce a lot of anxiety when it's pretty much a transient infection. For the most part, HPV infections will clear on their own.
Right. Okay. So, having reviewed some of our major changes, let's go ahead and sort of dive into the protocol and talk about some of the changes we've made. Let's begin by talking about how we can manage those non-compliant patients. And when I say that, I'm referring to patients that were indicated for colposcopy, they did not go. We see this quite frequently. It's one of those common issues we deal with on a daily basis. They were referred for colposcopy, did not keep the appointment. They did not come back for follow-up, and of course we know they remain at risk for cervical dysplasia. So what do we do? You know, they come back for annual exams. All we can do is continue to counsel them, reiterate the importance, and offer a repeat smear. Our protocol references a 3 to 6 month time frame on that. Actually, a 6 month timer is really preferred. Now, in these cases, you know, many of them do remain abnormal. They get referred again. We'll see how that goes. But in some cases, we do know that some of these non-compliant tracks, they fall back into a consecutive negative place. And then, so now you've got an abnormal result that prompted referral. And we have follow-up with 2 consecutive negative results. So what do we do with that? At this point, really the recommendation is to kind of throw it our direction, let Dr. Thomas sort of take a look at that and see what we can do as far as recommendations. Now, the rationale for some of this management is that repeating a smear within 6 months, you know, basically we'll be able to provide that referral provider with the most current results. I mean, that is it in a nutshell. And we can, you know, counsel the patient again at those opportunities. For the patient who does subsequently come up with a consecutive negative pattern, the purpose of talking to Dr. Thomas about it is just to let her look at it. If there, you know, there's a potential there that she could go back to routine screening at some point, but you know, there's a lot of variables that play into this. I think age and various things. Can you speak to that, Dr. Thomas?
Yeah, ASCCP speaks frequently about special populations. They talk about pregnant patients and they talk about women who are immunocompromised as well as other special groups. And I feel here in public health, and I do not mean this in any way, you know, to sound tongue-in-cheek, but we have a special population in that a lot of our patients do not follow through on their care for a variety of reasons, and we as clinicians have got to be sensitive to the needs of our patients. But I think that one of the things that we've got to understand also, that a lot of this is fluid, and it's just, we've got to look not only at the age of the patient, we have got to look at what was the indication for the referral initially to colposcopy, because that will sort of frame how the patient is managed down the road. You know, ASCCP came out with a supplemental article just to cover these guidelines, and in one of the beginning paragraphs of this little supplemental booklet that they came out with, they speak to the fact that even after treatment and negative surveillance thereafter, you know, after treatment, patients have had negative PAPs, just like in the scenario Lori has described, the risk of SIN3, you know, or again, that precursor for cervical cancer still remains. So we still don't know whether these patients can move to routine screening, which would be every 5 years, or whether they need to be kept at a 3-year interval. So all this is it's kind of like a bit of a moving target, and it's all in flux. So we've got to constantly, I guess, look at these cases and sort of discuss them on an individual basis.
Correct. And I think the take-home point there is counsel the patient, counsel the patient, counsel the patient, and offer that, you know, all we can offer is that Pap smear. So we've talked about the patient who hasn't followed up. What about the patient who actually went so far as to get her colposcopy, but didn't intend to follow up or go back to the referral provider based on his management plan? So what do we do in those cases? What we want you to do is follow those UAB post-colposcopy guidelines that we do have in the manual. Certainly UAB, they are the experts in this field. We rely on them for their guidance. And in most cases, in a post-colposcopy setting, those guidelines fit quite nicely with how we are to manage them with a co-test, a cytology only. And so that's what we would want you to do, and it is, their guidelines do, they are based on age of the patient. So let's talk about an example of when we would want to do that. So you have a 28-year-old, and we've referred her for a low-grade smear. We get the colposcopy results back, and they're indicated as SIN 1. The management plan by the provider was provided, but the patient opted to not go back because of financial constraints. So what management is required in a case like this? Well, let me first say that if there's a provider in the mix and they've provided recommendations, try to follow those recommendations. They may not always follow and just in line with how we might do business, but that's really the first line. If that result that he recommended in 6 months or whatever is abnormal, guess where she's going? Back to him. So that would be our first option. Second option as a backup plan is to use those UAB guidelines. So in this case, we've described the patient with the low grade. She was found to have SIN 1 on her colposcopic evaluation. So what UAB has provided for us is that they recommend the patient be referred back to us, and in a 12-month time frame, if that patient is 30 or older, she'll receive a co-test. If she's under 30, then she'll receive the cytology only. Now let me just kind of, that's kind of the quick and easy version, but we sort of all need to be aware that the colposcopy is not just a little summary. There's various pieces of that we need to be real familiar with and become comfortable reading and understanding. Can you kind of elaborate on those results and what they need to be looking for?
Yeah, I think I would just urge you, this is a great example, I think, of where things are concordant. And by that I mean that the cytologic findings, the low-grade cell, matches the histologic, the tissue diagnosis, the SIN, the cervical intraepithelial neoplasia 1. So we know that there's a direct correlation between those two. Those two match more than anything else. So that when you look at your colpo reports, and many of you know this from our conversations or the consults that you've sent me, you've got to look first to see if the colposcopy is satisfactory or adequate. And by that I mean, has the whole transformation zone been visualized? That'll make a difference in terms of treatment and observation, how you manage the patient down the road. You also want to look to see if an endocervical curettage, or what we call an ECC, an endocervical component, was done or is there, because that matters as well. And then you want to look to see if a cervical biopsy was done. Sometimes no biopsies are done. It's just listed as a satisfactory or adequate colposcopy, and that's fine, because again, as I mentioned earlier, we're moving away from the aggressive treatment of these types of lesions, low-grade lesions and SIN 1 lesions that we know in most cases will regress. These are HPV-type infections that more than 90% of them clear within 2 years.
Very good. So moving on to a little bit of a different situation. So how do we manage discordant results? And what I mean by that is we have a discrepancy between our pap smear and the colposcopy findings. An example may be a high-grade pap smear. We get the findings back on the colposcopy. It's negative. Perhaps we don't really have a treatment plan that's in our hands. We're not really sure what that provider did to manage that discrepancy. Again, we're sort of stuck in a hard place because we have a discrepancy. I'll go ahead and tell you that our lab, part of their QA process is to obtain colposcopy results on their high grade and some of those abnormal smears. They specifically ask the counties for those results, and if they are discrepant, they reread the slide. So there's you know, it's important to address the discrepancy when we come across it. So if that provider didn't provide it, and we can't get that from him, Perhaps he was going to monitor her a second time. Maybe he was going to recolpo her. Whatever the case may be, in a case like that, again, we need to get some recommendations from Dr. Thomas. We need to provide her as much detail as possible, the series of pap smears, the timing, her age, all those important things that help, to understand the whole scope of the issue. And as many of you recall, in our prior protocol, there were several areas where either there was some ambiguity to a case, there was a discrepancy going on. We sort of lumped them into an annual smear batch. I think what we've found through these studies is that really that's not justified anymore. It's over-testing potentially. So in a case like this where you have a discrepancy, you certainly want to attempt to obtain that management plan whenever possible. And then, of course, consult Dr. Thomas if we need to sort of see the path. I think it speaks to where we've already been this morning, but a discrepant case is difficult.
Yeah, truly it is. I think that there are three management approaches with the discrepant PAP, and Lori alluded to one earlier, and that is to have the lab or the pathologist review the slides. And in the past, the way these were managed is you had an excisional procedure done. You had something like a loop or a leap done, same procedure, but you actually removed a piece of tissue. It was not an ablative procedure that was done. It's not the cryotherapy. You actually would want to get tissue. So that whenever you would have a discordant result, in other words, your pap smear does not match what you see colposcopically or histologically, the two don't match, you would want to remove tissue so as to make sure that you're not missing any disease. So the other option would be to repeat your cytology and HPV test in 12 and 24 months, and that's any of those options are recommended or are acceptable according to ASCCP.
Okay. So, excuse me, let's go ahead and move on to some of our screening guidelines. Now, a lot of those didn't really change. We'll bring out a couple of the things that did change. So I think most of you recall that we are screening women 21 to 29 with cytology every 3 years. As we've already mentioned, we do have the new little carve out for the women 21 to 24 in regards to the ASCUS results, and that we will no longer be performing that reflex HPV on those women in that group. Again, the prevalence of HPV is there. It's transient. It tends to, with the body's immune system, clear within a couple of years. So we're not going to be doing HPVs in that group. It's not really going to change our management. So that is something I want everyone to be real clear on. Excuse me. And so that leaves the 25 to 29 year group that for them the screening didn't change. It's still a 3-year regimen, but for them we will reflex that HPV if ASCUS is identified in that group. So status quo with them. For our 30-year and older bunch, and this applies to family planning and breast and cervical cancer patients, we'll continue to perform that co-test every 5 years. And when you're speaking to breast and cervical patients, you have to sort of consider when you would discontinue that screening. So they tell us that screening should be discontinued after age 65 in women with evidence of adequate negative prior screening results and no history of SIN2 or worse. So what are adequate negative screening results? ACOG tells us that an adequate negative prior screening result is defined as 3 consecutive negative cytology results or 2 consecutive negative co-test results within the previous 10 years, with the most recent test performed within the past 5. If you can meet that criteria, then that woman is eligible to be discontinued from routine screening. Again, these are low-risk women that we're referring to here. Now let's move on to the high-risk patients. Again, not a lot new here. I think we're all familiar with who is high risk, and in our case, this would prompt an annual smear for these women. Of course, that includes the women who are infected with the human immunodeficiency virus, HIV. Now, let's not forget that in this group, CDC does recommend that these women infected with HIV should have cervical cytology screening twice in the first year after diagnosis, and then annually thereafter, which is typically probably where we might come in to that picture. So other high-risk groups include women who are immunosuppressed. Examples of those include your women who have received chemotherapy if they're within that 5 years of treatment. They have received an organ transplant, or they're those with chronic steroid use defined as greater than or equal to 6 months of use. So that's all pretty much status quo. Annual smears would also be required for the women who may have been exposed to DES in utero, and those diagnosed with cervical cancer. Now, as far as how to screen them, they're getting a PAP every year, so we certainly wouldn't want to co-test them every year. So we've sort of defined by age what our expectation is for that. If they're age 24 and younger, we use the cytology only method. If they're 25 and older, we actually will reflex it if it's an ASCUS. Now, we've mentioned here that a high-risk patient is one diagnosed with cervical cancer. We've mentioned that that pre-cancer setting where it's the SIN3. I wanted maybe just a quick description of when they would see cervical cancer defined on a result versus pre-cancer. How would that sort of look for the nurses that are reading those results?
Usually, if there is invasive cancer or a suspicion of invasive cancer, the pap smear is going to be read as malignant. Keep in mind that, HPV infection and the precancerous diseases are on a continuum. And I think that's really important to understand. They're decades before you get to cervical cancer, which means that there is invasion. That's what that means. And anything SIN2 or SIN3 are considered precancerous lesions. I think that the most difficult precancerous entity there is SIN2 because it's difficult to reproduce. It doesn't really match up really well with any findings that it progresses to cervical cancer, and some of it does regress. So that's an issue. There is currently a project called the LAST project that is trying to align cytology and histology. So you will get kind of unified a nomenclature. So you will have a low-grade SIN, a low-grade cell that matches up with SIN1 because we know there is that direct correlation, and a SIN3 that matches up with high-grade disease on a pap smear. And there is still a lot of controversy surrounding SIN2, but it's still the threshold for treatment in this country. That's not something that most clinicians will ignore. We will still go ahead and treat. In other words, we're still lumping those two together, SIN2 and SIN3 together. So that's kind of how you have to look at it on a continuum, on a spectrum. SIN1, keep in mind that's where we observe. We don't do anything, in that regard. Even beyond 2 years, some people may opt to just continue observing and watching SIN1 because it's considered to just be the HPV changes that are occurring and is likely in most instances to regress.
Okay. So I kind of wanted that description of the difference between a diagnosed case versus that precancer, because we tried to sort of formulate in the protocol what we're calling a safety net. In the past, again, this was a batch of women that were thrown into an annual screening mode. But this would be the women who we've got on file that they were diagnosed in some prior event with a SIN 2 or 3. And we have that on file, or perhaps we have a patient whom they give us some verbal history of treatment. You know, from what they're telling us, it sounds like they had a LEAP, they had cryo, they had something. We don't have records to validate this. So in both of these cases, we know these women are still at risk. So what do we do with them? We don't feel like it's justified to keep them in an annual mode. So what we're asking you do is sort of get a foundation of results on them that we're comfortable with. Some of these patients, you may already have these results in place, and that would be great. But we would like to have a co-test on file at 12 and 24 months, regardless of age. And you know, if those come back as negative, then we're pretty comfortable in allowing them to go to an age-based screening every 3 years. But keep in mind, remember, folks in that group, even though we don't have papers to prove, or maybe we do, they continue to be at risk for the next 20 years after that initial post-treatment surveillance period. So this is sort of our way of getting a foundation of where they stand. We've got results in hand, and then we can carry on their care in a more comfortable way. Now, let's go ahead and move on to actual PAP results that include those unsatisfactory results. Now, we've already mentioned it earlier, so we're just going to kind of overview it. So if you've got unsat results, if you're HPV positive or negative, you're still going to repeat that cytology in 2 to 4 months. If the negative cytology and negative HPV is what we have in the end, then they can go back to their routine screening based on age. Obviously, if that result comes back as abnormal, we follow the protocol for that abnormal. But this is the interesting piece. You know, if that patient continues to have unsatisfactory results, we need to evaluate that. And in most cases, it's going to prompt a colposcopy referral. Do you want to speak to that for just a sec, Dr. Thomas?
Yeah, I think the unsat cytology report or pap smear result is always a bit concerning because usually there's some kind of obscuring issue such as blood, and we know that postcoital bleeding or irregular bleeding could be a sign of cervical cancer or certainly severe dysplasia. So that's something that we don't want to ignore or sit on. So if a second pap comes back unsatisfactory, colposcopy is what is recommended in that setting.
Okay. Excuse me. So a lot of times those results, as we've already heard this morning, they're based on insufficient squamous cells. It's often the cause. Optimal results can be obtained with the use of extended tip spatulas, spatula plus brushes and brooms, which all appear to help minimize unsatisfactory results. Of course, this is guidance that's been provided by ASCCP. They also recommend that when using 2 of these devices, the ectocervical device or the spatula should be used first. Now, there may be some other indications maybe at the time of the exam we would want to keep in mind, such as counseling the patient about sexual activity and that type of thing.
Right, and I think those are still in place. Patients should refrain from sexual activity at least 48 hours before having a pap smear. Tampon use, similarly, any intravaginal medications or creams. I think that's
pretty much it. Okay. Okay, so let's move on to some of our abnormal results. And, you know, I think this is one area that we have changed a lot. And it's the ASCUS or low-grade results that are in the age group of 21 to 24. Now, our protocol is new. It's something that I think we've had more questions about than anything, and that is that in this age group, the reflex HPV testing on an ASCUS will not be done. I think we've made that clear today. The recommendation, again, is more of that monitoring mode, so we're going to repeat that cytology at 12 and 24 months. And if both of those results remain negative, then they can actually go back to routine screening based on age. Now, along the way, if we have a result that perhaps they continue with an ASCUS, continue with a low grade, basically what we want to do is get them to a 2 consecutive negative place. Now, along that way, if their result worsens, they have an ASC-H. They have an ASCUS or low grade result with the comment cannot exclude a more severe lesion. That buys them a colposcopy referral. So keep that in mind. That is definitely something we would not want to keep. You got to look at those PAP results, really read that. That can somewhat get lost in the shuffle sometimes, but I think that language about the cannot exclude a more severe lesion, it's significant. And did you want to speak to that for a second, Dr. Thomas?
Well, I think the one thing I wanted to point out, patients who we've got this new carve out, this 21 to 24-year-old carve out. And again, as Lori reiterated, it has to do with the fact that what we see in this age group is largely just HPV infection that's going to be transient. But if you have got a patient who is less than 21 years old and who for some reason had a leap in the past or has a history of SYN3, all bets are off. Those are patients that you want to keep a close eye on and that you want to follow. They're on a different path altogether. So we've got to keep that in mind as well.
Okay. Okay, so let's move on and talk about the patient who is in the, let me figure out where I am. Okay. Since Dr. Thomas has so eloquently already covered this information, we'll move on to the 25 to 29-year-old. And so for them, again, just to refresh our memories, they do get a screening every 3 years with cytology. But in this case, we are to perform a reflex HPV if ASCUS results are identified. Now, along with them, again, that ASCUS negative is not really negative anymore like it used to be, and their path is really to repeat that co-test in about 3 years. Now, you'll notice that we've included this lifelong risk, and that's kind of new to us. We've identified it here with our ASCUS negative results, and we also identify it with our negative cytology results that have an HPV positive. Now, we'll talk about that lifelong risk in just a moment. But when you have a patient, though, that's in this age group, you're dealing with an ASCUS HPV positive. Clearly, that's no different than what we've always done. We refer them for colposcopy, and that's still done. So who is at lifelong risk? I've mentioned the ASCUS negative. I've mentioned the negative cytology that has an HPV positive, and then that HPV positive goes back to negative. So what is the big deal with those? I think a lot of it has to do with, as Dr. Thomas has already mentioned, the Kaiser Permanente study helped to sort of solidify for us that it's really not warranted to push them out to 5-year screening. They have some risk, so we're going to monitor them a little closer. And that's pretty much it in a nutshell. And, as she mentioned, this is sort of some good background from that study. For the ASCUS negative case, they found that while the absolute risk of SYN3 plus was low, after an HPV negative ASCUS, it was more comparable to a SYN3 plus risk among women with negative cytology alone than those with a negative co-test, suggesting a 3-year interval for follow-up. And I think Dr. Thomas really covered that well earlier. Now, in addition, women over 60 years of age with an HPV negative ASCUS, they had a higher risk for cervical cancer during follow-up than women with a negative co-test, suggesting that they needed continuing screening. So again, I think we've touched on that earlier. We can't stop their screening if we've identified that ASCUS negative with those women. Now, the interesting thing about the negative cytology HPV positive case is what they tell us is that despite negative cytology, women with oncogenic HPV are at a higher risk for later CIN3+ than women with negative HPV tests. I think we know that. The risk of CIN3+ in HPV positive but cytology negative women is sufficient to justify that early return for retesting. I think this Kaiser study, as we mentioned, it just sort of solidified that there is risk there. We're going to watch them a little closer, and that's pretty much it. Did you have any other thoughts on that whole risk factor situation?
No, I think I
think we've covered it pretty good. Okay. So let's talk about the ASCUS result in a patient who's 30 and older. Now, usually we're going to identify this through the patient who's getting a routine co-test. That's typically where this comes about with her screening. The protocol tells us that if we have an ASCUS HPV negative, we're going to repeat that co-test in 3 years. Again, same song. They will have that lifelong risk, so they'll be getting those tests every 3. Obviously, if they have an ASCUS HPV positive result, they are referred for colposcopy. Your ASCUS results in the postmenopausal women, they're a little different. I think for those that are under 65, it's what we've already mentioned. But if they're 65 and older, the management varies just a little. You have a patient who, in that case, will receive a repeat co-test in 1 year. So that tracks a little bit differently. We're going to watch them a little bit more. In that case, if those results are negative, they'll still get co-testing every 3. So they continue to have that risk in the postmenopausal situation. So let's address the low-grade results in the women that are 25 and older. As we've always done with this, we're going to refer for colposcopy. However, you know that in this prior protocol, we did a bit of a trial. The ASCCP guidance really had a couple of tracks of management here. They allowed us to actually reflex an HPV, and you could triage it that way and manage that way. We attempted that. We reviewed our data from that with the lab. But as you have now seen in October, we've omitted the HPV reflex. Our data indicated very clearly that most of those cases, sort of as we expected, were HPV positive. It prompted referral anyway. There really wasn't any significant savings that we were maybe hoping to see by triaging them with an HPV. So we're sort of back to the old way of doing business, and so they're going to just get a referral for colposcopy, as we've done in the past. So the low-grade SIL in a postmenopausal woman, again, this is a little different. We are going to perform that reflex HPV to triage them. That's new to us. If they are HPV negative, they'll repeat that cytology in 12 months. And again, if we have that negative place, we can put them into a every 3-year mode. Now, before we move on, there are some interesting things about postmenopausal women. I think a lot of this low grade in the mix has a lot to do with their changing cervical and hormonal issues.
Yeah, I think one of where we see HPV testing being of great value is in the postmenopausal setting, because we know where the prevalence of disease is. It's in the younger woman, so that when you see, that's why we can use HPV as a co-test at age 30, and because the prevalence decreases with age. So that if you've got a postmenopausal woman and she's got a low-grade SIL and she's colposcoped and you're not really finding anything there that you can really sink your teeth into. Oftentimes the colposcopy is not going to be satisfactory because the patient is postmenopausal, so that the squamocolumnar junction is kind of turned inward on itself, so that in itself is going to make the colposcopy different or difficult. And then there are hormonal changes that are associated with the menopause where you see atrophic changes as a lack of having estrogen on board, and so some of those factors could lead to kind of skewed findings on your colposcopic exam. So having the opportunity or having HPV available to reflex would be helpful in terms of weeding out the non-disease, so to speak. So that if you've got a patient who's postmenopausal, low-grade SIL, I think it would be prudent to do an HPV test so that if it is positive, you know that she's got to go to colposcopy and you've got to follow that track.
Very good. Okay, so let's speak to the hysterectomy situation where we've got a patient or a woman who's had a hysterectomy. ACOG tells us that these women should continue to be screened if they have had a total hysterectomy and have a history of SIN2 or higher in the past 20 years or a cervical cancer ever. Now, of course, one thing that we do know is vaginal cancer is rare, but we know that this group remains at risk, and so we are going to continue to screen them of the vaginal cuff just to kind of monitor their well-being. You know, again, that 20-year time frame could go on past their normal 65-year drop, but they would continue to be monitored. Now, as far as sort of the lingering protocol issues, I think we all have now become familiar with the new UAB colposcopy guidelines. They do tend to update them in line with ASCCP, so that is what they've done. I think the post-colposcopy management, when it's not provided or, as we've mentioned earlier, it's not available, we should try to use these guidelines to sort of help fill those voids. Now, patient counseling. Sort of wanted to touch on some of the tidbits and things that we've learned through this process. So you have an ASCUS HPV negative case. You know, again, I think as Dr. Thomas said, we don't want to cause undue worry, concern. So in general, these patients, they can be informed of their ASCUS negative finding at the time of their routine visit. They're not thrown into a follow-up mode. We basically just have them on a different schedule, for lack of better words. Now, unless that particular finding is in a post-colposcopy setting or treatment setting, that's not what we're talking about here. Those would still fall maybe in that tickler setting. But just as a general statement, ASCUS negative does not warrant all of that follow-up. We're not going to tickler those folks. Now, another situation that's come to my attention is, say you have a patient who has that negative cytology, she has a positive HPV, she transitions back to a negative HPV, and now she's on that Q3-year mode. That's her new strategy or her new regimen for screening. I've had nurses call and say, well, are we going to tickler them? Are we going to have them on reminder every 3 years? No. When they get back to that routine screening place, we're not going to require all that tickler and follow-up on those patients. So HPV vaccination, clearly we know how important it is. My goodness, if we could vaccinate everybody, maybe we wouldn't be doing all this follow-up, right? But it's important to counsel the patients age 19 to 26 about receiving this series. I think we're all aware that there's a statewide program going on right now in our family planning clinics across the state to actually provide HPV vaccine to these to our women. The immunization folks tell us that there's been over 18,000 doses that have been distributed to the counties through this initiative since it started. You know, we've looked at a little bit of the data. We're seeing some really good return on this. We've got some counties, I'm going to give kudos to a couple. I know you're bigger counties, but Tuscaloosa, Montgomery, doing a wonderful job. You're in the triple digits on the dosage you're giving out to the patients. We appreciate all that hard work. Please continue to encourage this. We have been in touch with our Merck representatives, and they're actually out there trying to help us by providing some neat little gadgets and things that to help remind patients about the series. I think they've got some magnets and some wallet cards and posters and lots of really cool stuff that they showed us. They told me yesterday that they've gotten about half the counties distributed with this materials. So for those of you who may not have seen these coming yet, you should see them in the next 2 to 3 weeks. So I think counseling the patient about HPV is so important. Have you got some tips for us on that?
Well, I think we've got to develop a strategy that is both educational and informative, and I think it's important to disclose accurate information to our patients and counsel them effectively and compassionately. And I know this is a difficult task at times, but there are a few things I think that I've mentioned earlier that I think if you stick to this routine or spiel, should kind of help to get you through that. And I think one of the first things that the patients need to understand is that the infection is pretty common after sexual debut, and for the most part, HPV infection is benign. It's transient. When you see persistent infection, that's when that should raise a red flag, because persistent infection equals a prerequisite for cervical cancer. Most cervical cancers occur in women who have never been screened or women who are underscreened. So we want to encourage our patients to adhere to the guidelines as to when they need to be screened. Also, we know that there are risk factors that are associated with developing cervical cancer, such as early onset of sexual activity, multiple sexual partners, having partners who are high risk, a history of STDs, in particular chlamydia. So we want to encourage our patients to limit the number of sexual partners, to not use tobacco products because they are also associated with an increased risk of cervical cancer, to use condoms. So the take-home message again, regular condom use, limit your partners, show your patients that sexual partner chart that we've got pretty much in all county health departments across the state, that shows the number of partners on one axis, and then on the other axis it shows your exposure rate in terms of numbers of partners, and that always seems to heighten their attention, and I think that's important. Encourage routine screening for sexually transmitted infections, because we know they go hand in hand. And HPV vaccination. That's going to be the key to eliminating cervical cancer here in our country.
Very good. So speaking of take-home points, let's touch on a few of those. So as we've said, screening is our big success story. Cervical cancer was once the leading cause of cancer death in women in the United States. The American Cancer Society tells us that between the 1950s and 1990s, the death rate declined by almost 70%. Most cervical cancers, as Dr. Thomas just mentioned, they occur in those women who have either never been screened or they're inadequately screened. As we all know, HPV infections are commonly acquired in the younger women shortly after initiation of sexual intercourse, but in most cases they are cleared by the immune system within that first couple of years without producing any precancerous or cancerous changes. The risk of neoplastic transformation increases with those women with persistent infection. So some of those cases where we watch them and it just continues and continues. They continue with that HPV infection. That's persistent. And so generally speaking, those are going to end up in a colposcopy setting before it's over with. Counsel those patients about getting screened. We're really good at that. we have some really great nurses out there that really can help these patients to understand, and they counsel, and they want to just take them home with them, and we know that. But counsel them. It's our best defense. Screening offers the best chance for the early detection of cervical cancer and successful treatment. Getting the HPV vaccine, again, that is key before being exposed to HPV. It hopefully will prevent some of that. Have to touch on the PAP requisition just a little bit. We know it's important. I think the nurses and nurse practitioners do a great job filling out that requisition. It's not always easy. The lab needs to know that prior history. They need to know what you're obtaining that specimen from. They need to know about that prior history. Was there a leap? Was there some hysterectomy in her past? I've had discussions with the lab, and I think we're trying to actually put into place some rules, so to speak, that sort of fits our protocol, where, because we are so accustomed to marking the requisition a certain way, our protocol sort of transitioned away from maybe getting that HPV. So you may be getting calls from the lab questioning whether you really meant to get an HPV or not. We know that's going on, and we're going to work through that transition. We've also had discussions with the lab about ways that we can communicate better with them. So let me give you an example. I think we had one just this week. I had a patient who, based on her prior history, she was still under 30, but her recommended management per Dr. Thomas was a co-test. Generally speaking, the lab doesn't expect you to order a co-test if they're under 30 years old. So they're going to debate that one. So what might help this transition is in the comments section on the requisition, make a notation, co-test ordered per Dr. Thomas, post-colpo co-test, because they're gonna honor that. They just don't want to inadvertently do an HPV that was just for screening that shouldn't have been done. So hopefully that will help a little bit there. Now we're going to go ahead and move on to some case studies, and these came from our own consults. Some of this was done early on, as we were transitioning. So let's just sort of look at where we've been and where we're going, and this may help sort of solidify some of the things we've discussed today. So let's begin with a 30-year-old. She's a gravida 0. Her history of abnormal PAP results are present there since 2007, so she's got this past. Her most recent PAP result indicates a high grade, cannot exclude a more severe lesion. So clearly we referred her on to UAB. So her colposcopy results indicated carcinoma in situ, SIN3 involving glands. Also a part of her results, it indicated a high-grade dysplasia focally present at the inked margin or at the inked specimen margins. So in this case, UAB performed treatment, which was a LEAP, and they recommended repeat PAP in 6 months with an endocervical sampling. So will a good cervical sampling that we can provide of the ECC actually be adequate? Is this what they're looking for in a case like this? We brought this one to your attention because we've had several come up, and we've had to address them. So the clear answer is that what they're looking for is an endocervical curettage that is something that typically get under the colposcopy setting. We don't perform that. We get a cervical, endocervical specimen, but it's different. So I was hoping maybe, Dr. Thomas, you could elaborate on this a little better for us.
Yeah, the first thing I'll touch on is the inked margin and what does that mean. And again, it's just to emphasize that you've got to, I'd like for you to look closely at the colposcopic report that you get, and just pay attention to things, and we can talk about this. This is a new area for lots of folks. It's not something that we're familiar with, but it helps to connect the dots. What the inked margin means is that, say, for example, in this setting where you've got SYN3 and CIS, carcinoma in situ, and all that means is that there are cells that haven't, there's no invasive disease. That's what carcinoma in situ means, that it's contained. There are malignant cells there that are contained. It's to the inked margin. So in other words, when a leap was done, or loop, and that's a large wire that looks like a loop, and it's got a handle, and basically we sweep it across the cervix and you get a piece of tissue. There are a lot of problems associated with that. Sometimes the ends can be cauterized too much and you can't read it properly, or you've got disease right up to the margin where you made between what we consider normal tissue and the tissue that was removed. So that's what disease at the inked margin means, that you have possibly left behind some disease. So the question is, how do you handle that? How do you handle it when you think you have got some residual disease there? And so this issue has come up, believe it or not, quite a few times, and we've gotten the recommendation from UAB, which is appropriate, that patients get an endocervical curettage, which we do not do, and usually it's a pap smear. And I think it's between 4 and 6 months, if I recall correctly. That's the recommendation. There is controversy surrounding whether or not an endocervical curettings or scrapings using a cyto brush, which is what we can do, is equivalent to using a sharp curette, which we don't do. In other words, using an instrument to kind of scrape the endocervical canal. The consensus is that the two are yield about the same in terms of sensitivity. So therein lies the controversy. And at UAB, the thinking is, and Dr. Ha, who's at UAB, and many of you have, I think he's been here before and talked to us before, he is one of the architects of the ASCCP guidelines. So this stuff is coming straight from the horse's mouth. So I think we're privileged to have the backing of UAB. But the point I'm trying to make is that there's controversy as to whether or not we can use the cyto brush to get that specimen as well. So in the interim, the guidance is, what the nurse practitioners have been doing is talking directly to the clinicians at UAB, which is great, and they're usually giving guidance as to what they want done. And I imagine that's based on what the what the initial referral was for. So that again requires a little bit of communication and going back and forth. But the important thing is that I want you to become familiar with what the colposcopic results show, what the LEAP results show, and if it's not clear to you, we can talk about it and help to clarify it. But the inked margin means that there is disease. You have possibly left residual disease behind.
Right. And as Dr. Thomas mentioned, many times it takes different eyes looking at it just to make sure we're all on the same page. Okay? So we're going to move ahead in the due to the time factor. Let's go ahead and move on to PAP case number 3. So we've got a 23-year-old who had an ASCUS HPV positive result in 2011. And, the purpose of bringing in some of these that have prior history is because this is where we are. Many of these patients are transitioning with this prior history in the mix. So this patient had it back in 2011. Colposcopy was indicated at that time. So the results showed the endocervical component had no dysplasia. The ectocervical component had atypical squamous metaplasia with mild epithelial dysplasia. So in her case, there was a repeat smear in 2012. She had negative PAP result, but an HPV positive. So in this case, the provider opted to do a second colposcopy. Again, it was a year out. It was at HPV positive. They're still seeing that persistence, so they did a second colpo in her case. Same results, same results. So we did a repeat smear at the health department because isn't that how it works? They show up. And here we are. We've got this history. So we have a repeat smear by us this year, and we have a negative PAP with an HPV positive. So what do you do in a case like this? What choice do we have? We refer for colposcopy. And again, it's that concern of that persistent disease there. So case number 4, we have a 35-year-old. Back in 2011, she had a low-grade smear. Did not go to receive her colposcopy, as that does happen. A year later, she had an ASCUS HPV positive. Again, referred for colpo, opted not to go. So we're now into this year, 2013. She has a negative PAP, positive HPV. So what did we recommend for her? Again, refer for colposcopy. Stress that importance of the colpo, that what those results, reflect, and that there is persistent disease there. So we have a 24-year-old in case number 5. All the way back in 2008, she had a low grade, but notice that she cannot exclude a more severe lesion. Now, at that time, she was 19, okay? Now, we would still refer based on that finding now, even if in the 21 to 24 year range, but for her, she was 19 and had this result. Now, 1 year later, they repeated, had the exact same result again. And at that time, she was 20. So she was referred clearly and did not follow up. So here we are, 2013. She's now 24 years of age. We did our PAP because we need to see where we are. And, of course, we get an ASCUS HPV negative. So what do we do for her? Well, this was a unique one. We wanted y'all to see this one because it's such a young patient. Again, you've got that HPV transition in the mix. So basically what we informed the nurse to do in this case was, given this backdrop, albeit the patient was less than 21 years old at the time, we actually recommended a repeat PAP with HPV in 12 months. A co-test. Again, this is where Dr. Thomas can help us to get comfort in knowing which direction to go in. And we're just going to watch her closer. Okay, we want to leave a few minutes for questions, so we're going to run through these quickly. Case number 6, you have a 23-year-old. She had a high-grade PAP back in 2011. She did not get her colpo. She comes to us for her annual exam. The notes indicate no cervical lesions. She actually had a negative PAP and a negative HPV. She doesn't mention any prior or any abnormal PAP since then. So what do we do for her? In her case, we're going to repeat the PAP and HPV in 1 year. And in both, if both are negative, then she can actually go back to age-based screening. So we have a 35-year-old back in 2012. The PAP results received from the private MD's office. So that's good. We're getting those more often these days. She had a negative PAP with a positive HPV, so we now have that on file. This year, the health department did our PAP. We found a negative PAP, HPV positive again, so we now have it 2 years in a row. So what is her next step? Based on the age of the patient, the persistent HPV status, we're going to go ahead and refer her. Now, I want to go ahead and encourage the counties. Feel free to go ahead and call us. If you've got questions, if you've got any points of clarification, feel free to go ahead and be calling in. I will sort of stop the case study discussion and we'll try to answer any questions that we can. I hope you all know that my email's open all day. My phone lines are open all the time. So certainly once you've had time to soak this in, look at what we've discussed today, you can always call and we'll do what we can to answer that. But in the interim, we'll keep going. So we have a case study number 8. We have a 25-year-old that has the following history. Back in 2008, she had an ASCUS HPV positive. A year later, she had an ASCUS. A year later, she has a negative. So we'd like to think that, okay, she's regressed, it's gotten better. but we see her 3 years later and she has an ASCUS HPV negative. So she's got a little bit of history here. She's still young. So what do we do for her? We're going to repeat that PAP and HPV test in 3 years, that co-test. Case number 9. So we have a 22-year-old seen last month for her annual exam. PAP results indicate ASCUS cannot exclude a more severe lesion. Now, based on our new guidelines, what management do we follow for her? She's 22 and she's got this result. A patient of any age with those results, ASCUS cannot exclude a more severe lesion, are to be referred for colposcopy. Again, make sure to read those PAP reports in its entirety. Make sure that we don't miss that. They're seeing cells on that smear that look to be more in the high-grade realm. So we can't ignore that, and they need to have further evaluation. Last example is our 60-year-old woman who presents for her annual exam. She reports that at the age of 48, she actually had a hysterectomy for cervical cancer. She has been without any evidence of disease since and wonders does she need an annual screening? Does she need an HPV testing? How do we manage her? So in her case, the patient is considered high risk again. She's got that 20-year factor in the mix, cervical cancer in the mix. So she's considered high risk based on that past, despite the hysterectomy. And we're going to continue to do annual smears of the vaginal cuff on her. Now, in all cases, you know, the nurse and nurse practitioner should document, again, that pertinent history on the pap smear requisition. So I think we have covered a lot of information today. We tried to do an overall review of the protocol. We've tried to hit areas that have been having more questions come in about. But again, feel free to call us with any questions, and we'll sort of hang around for a few minutes for that. Any last-minute comments, Dr. Thomas?
The one thing I'd like to clarify, and this is something that we're working out with the lab, we need to get a clearer picture, I guess, of an ASCUS cannot rule out a higher grade lesion is not consistent with Bethesda. That is really an ASC-H, and a typical, you know, that's a high grade PAP. And if it's either ASCUS or it's ASC-H, which, as you guys know, tend to be in the high grade realm. So we're talking, if it's either ASCUS or high grade, it can't be kind of like in between. So it cannot be ASCUS, cannot exclude a more severe lesion. So we're working with the lab and to try to not have those kinds of results that are not within the Bethesda system.
Okay. Do we have any questions that have come in through the email? You did a good job, Dr. Thomas.
No,
She makes me look good too, which is good. Well, we won't delay. We certainly encourage any questions. We know this is new. As we said at the beginning, transition is hard. Unfortunately, in this world, it's probably going to continue to evolve, and we will continue to provide as many updates, as many face-to-face phone calls, anything it takes to help us all be on the same page, and just encourage you to call us when needed. Go ahead.
Just thank you for all you do, and I know that this is a hard time in terms of the transition, but we got to just settle in and get comfortable, because it's going to be evolving, as Lori said. My line is always open as well. If you can't reach me, you guys have 3 numbers, or you can talk to Beth, talk to Lori. Somebody knows where I am to track me down, and I'm happy to answer questions from anyone. Please feel free to call.
With that, I think we'll end our program. We really appreciate you tuning in today. I know it's difficult to close those clinics down. and pull those nurses out, but it's so important. We appreciate that, and we hope you all have a great day.